So we're going to talk about something that I am really excited about, and I hope I'll be able to engender that excitement with you, which is extending our health span. And this is something that has only come about as a reality, as a prospect in recent times, because of things that are going on in biology and in AI and other domains. So let's get right into it. So as you know, I wrote this book. Some of you are going to get copies. Came out in the spring in May, and it was about the phenomena of super agers. That if you could roughly define it, people that got to the 85-year plus milestone never had cancer, never had cardiovascular disease, or any neurodegenerative disease. And so Lee Russell, who I introduced right from the beginning of the book, is a 98-year-old woman, patient of mine, and she exemplifies a super ager. And she is very active with her social connections. She walks every day. She's incredibly funny and crisp, and she's just totally intact. And she oil paints and has a gallery. So what's the story about her family history? Her mother died at age 59. Father at age 64, and her two brothers died at age 43 and 75. That doesn't suggest that health span, which she is the exemplar of, is heritable, right? Well, we did a study called the Wellderly. In fact, that was what I wanted to name the book, but the publisher said nobody will know what that is. But we did 1,400 people like Lee Russell that were average age 89 all the way up to 102. They had never been sick and on no medications. It took 7 years to find this cohort. And we did a whole genome sequence on all of them, and we found very little in their DNA to explain why they were super agers or Wellderly. And interestingly, many of them had a very similar family history of no relative living anywhere close to the index participant. Now, in the counterpart of the Wellderly is the vast majority of people who by age 65 have at least one of these chronic age-related diseases. And so this is the end of their health span. They no longer have a health span because they're now affected by one of these big three diseases. Now, interestingly, just recently, this journal had a report of a woman who at the time was the oldest living person in the world, named Maria Morera. And before she died, she asked her doctors in Spain, will you please study me? And they asked her, why do you think you live to 117 intact? And she says, because I have 3 yogurts a day. Well, it turns out they did the most comprehensive study ever of a super centenarian. Every possible assay you could think of, immune system and a gut microbiome, whole genome sequence, telomeres, all sorts of things. And what was interesting, if you look at all the data in this report, it's the immune system is what shined, as we're going to see is a theme across many studies of aging, as one of the key aspects that hers was particularly youthful. Now, on the other hand, outside of some of really science advances, you see this kind of stuff where these end of aging, it's just embarrassing to see consumer reports say 7 anti-aging supplements to try. There are no anti-aging supplements. There's lots of claims, but there are none. Living to 120, old age is over. All this bunk is out there. And that is clouding some of the real advances in science. The pills to end aging, there are no such pills, of course. Now, what's true is that there's a lot going on in the science of aging to try to slow or reverse the aging process. That's a daunting goal, which hopefully will be realized someday, but we're far from it. And the other side of this is what I'm trying to convey with you, which is the excitement I hope you will identify with, is that we have a newfound ability to prevent age-related diseases, okay? So we don't have to reverse the aging. We can just accept aging and modulate the individual from not having one of the major 3 age-related diseases. So this is an important graph from CDC data. And what it shows you is, but the average health span in the United States is 64, and the lifespan is 79. That means that 15 years of health span are lost compared to lifespan, that gap. And almost 80% of that loss is due to these 3 major age-related diseases. And you can see by age 40, almost no one has these diseases. And in fact, there's a very interesting flattening of cancer that occurs around 75. In fact, it starts to come down for various reasons. And then, of course, there's an exponential rise of Alzheimer's and neurodegenerative diseases starting in the mid-60s, as you can see in that takeoff there. So the point about this is that if we were to put people under surveillance for age-related diseases at age 40, since all these diseases, 3, take about 20 years to incubate in our bodies before we ever manifest symptoms, we could get ahead of these 3 major diseases. There's lots of different strategies that are being advocated to slow the aging, reverse the aging process. One of the ones that's getting the most funding of all with Altos and Retro, other companies, is this concept of epigenetic reprogramming, using Yamanaka factors and other means to basically turn back the clock at the cellular level. There's many other strategies, but the point is none of them have been tested in human beings to show any reversal or slowing of aging. They're very effective in mice and some in rats. And that's kind of where the story ends, at least right now. Some of them are getting ready to go into trials next year, not on a whole human basis, but in particular indications like severe knee osteoarthritis, that sort of thing. Now, what I want to submit to you is, while that science is ongoing, it has lots of investors that are trying to pursue that. At the same time, the biggest advance in this whole space are the metrics of aging, being able to track the aging process and quantify it. And so these are the molecular clocks. And there are these body-wide aging clocks that were pioneered by Steve Horvath. That's been now 15 years or so, and keep building on those. And then each layer of biology, there are ways to do body-wide aging assessment. How old is that person biologically by this type of data as compared to their chronological age? And then more recently, the work of Tony Weiscore and all his great crew here have pioneered organ aging, particularly proteomic organ aging. And there's also immune system aging and retinal aging, lots of different ways to assess particular organs. Now, if you look at the molecular clocks to track aging, they've gone through generations. There's really 4 generations of these whole body clocks. They rely on DNA methylation. And generally, the ones that are most accepted now are beyond the Horvath clock, this so-called Dunedin pace clock. The organ clocks are really what is particularly exciting because they're going to be widely available in the near term. And this is that classic cover of Tony's paper from 2023. And I think one of the figures related to organ clocks, the idea that we can not just understand that aging is a marked difference, heterogeneous between individuals, but within each of us. Our organs may age at a different pace. And now we can measure that for really the first time. And that includes the brain, the immune system, which is not an organ, but obviously very important, the artery, and so on. And in fact, some of the work from Tony's group, as shown here, looking at a big cohort with 17-year follow-up, the UK Biobank, showed that the brain and the immune system clocks, their pace of aging, was the most important for explaining this remarkable survival pattern. So we are learning about the immune system, and interestingly, we still don't have, almost at the end of 2025, a way to measure a person's immune system in the clinic. That's extraordinary. It's one of the most important parts of our being, and it's related to our aging process, and we still don't have a measurement of all the aspects of the immune system. Why it's so important is, as we get older, our immune system starts to fail. It gets dysregulated, it loses its protection, so-called immunosenescence. And this sets up the potential for the big three diseases and for the overall accelerated aging process. It also induces the process of inflammaging, untoward inflammation at various parts throughout the body. What we do know is that lifestyle can make a big difference. And interestingly, if you get a perfectly healthy lifestyle using the American Heart criteria at age 50, you get 5 to 7 years of healthy aging as a result of that, compared to those who have not followed these healthy lifestyle factors. So we do know some things that modulate the immune system, and lifestyle is a big part of that. There's a lot of interest right now in the GLP-1 drugs to do this, because they seem to have a potent effect of suppressing inflammation in the brain and throughout the body. We know sleep health is actually quite important as well, beyond even for neurologic conditions. And there's a big problem with environmental toxins that are taking us in the wrong direction, such as the microplastic nanoplastics, the forever chemicals, and air pollution, no less some of the ultra-processed foods that we ingest. So the case for intervening, preventing Alzheimer's now, I think, has become really exciting. And that's why we're launching a trial early next year, actually in collaboration with Tony here. And the idea is that we have all this knowledge about amyloid and tau, misfolded proteins accumulating in the brain. And we know when you ask people what is their most dreaded condition they could ever think of, it's Alzheimer's. And this is going up in a tremendous jump because of the aging demographics of the population here and around the world. So ApoE4 is one of the major risk factors we know for Alzheimer's. And 1/4 of us are carriers for ApoE4. And a lot of people say, I don't want to know because there's nothing you can do about it. Well, that's not true anymore. There's a lot you can do about it. And hopefully enough that you can prevent the disease or put it off for many, many years. And also, obviously, there's a much smaller group that are homozygous for E4, have a very high risk for developing Alzheimer's. All these years from 1993, when ApoE4 was first reported as a risk factor at Duke University, we didn't really know why it's a risk factor. Recently, lots of samples that have been used to understand what's going on here from plasma, from cerebrospinal fluid, has shown remarkable hyperactive immune system and inflammation, which likely responsive to triggers is a good part of the explanation for why ApoE4 is a risk factor. Now, what's a lot of people don't appreciate, and I already touched on this, these three diseases take 20 years. You don't just show up one day and have a heart attack or have Alzheimer's. You have a 20-year incubation period. If we can't get ahead of that, then we must be really dumb, right? We have 20 years to work with. So many people don't appreciate, but all the studies suggest that it takes a very long time, at least 15 years, and you can detect this through markers that are in the blood, in the plasma, that reflect an inflammation in the brain, particularly p-tau217, which has emerged as the most helpful in that regard. And so you can get ahead 15, perhaps even up to 20 years of defining the risk of someone developing Alzheimer's on top of ApoE4, polygenic risk factor, a definite family history. And there are other markers that can be put into a panel, such as neurofilament and GFAP and others. But all the studies to date, summarized here in a recent paper, suggest that p-tau217, whether that's alone or in a ratio, is the best one that we have to date. And in fact, just earlier this week on Monday was yet another paper. There's another one today, which this one had almost 8,000 participants summarizing 16 studies, and p-tau 217 accurately identified in the preclinical stage. That is, people with no compromised cognitive function. Now, earlier this year at the American Academy of Neurology, there was a small randomized study where they took half of the participants and they put them through rigorous lifestyle improvement. And this is one of, and a good example, but not necessarily dissimilar to the others in the intervention group. This was actually a nurse who went to a Mediterranean diet, exercised, lost 30 pounds, gained a lot of muscle. Her p-tau dropped 43%, her p-tau 181, which is another important neuromarker, dropped 75%. That's a really good sign, since temporally, not just yes or no, these markers predict over time. If you can suppress them to that degree, that's going to put off the disease quite a while. So this is encouraging. There are many studies now that have reinforced exercise in particular as a way to keep levels of p-tau suppressed. Now, besides the work on lifestyle, what's interesting is the work done here in particular on Alzheimer's disease and dementia suppression by the Shingles vaccine. Now, what's fascinating about this is not likely to having an active role against herpes zoster, but it does have a big impact on the immune system. And there are 3 large natural experiments summarized in this figure. 2 of them are from the group here, and they basically show a 20 to 25% reduction of dementia, of which 70 to 80% is Alzheimer's. Now, there's a new paper that came out yesterday in Cell, again from the group here. So 3 out of the 4 natural experiments are from Pascal Geldsetzer. I don't know if he's here, but this is phenomenal work. If this was a drug, this would be considered a blockbuster to reduce dementia and Alzheimer's disease. But because it's a vaccine, people don't understand this is actually a really big deal. Natural experiments done in Wales and Scotland and the US, these are huge, better than randomized trials, because they're not selecting people with inclusion criteria, exclusion criteria. These are looking at the whole population. And in this new paper in Cell, it wasn't only affecting the onset of mild cognitive impairment, but it was slowing the progression and preventing deaths in people who already had dementia. Pretty striking evidence, keeps being reinforced about the value of shingles vaccine. So we have a modulator of this disease, no less. Lots of promise with lifestyle factors and lots of drugs out there that are candidates, no less supplements, for example, like lithium orotate. So the idea in our trial is to randomize people. The first phase is intensive lifestyle coaching versus just educational materials, as was done in a recent study for cancer that showed marked improvement of survival. For high-risk people that have all the features of high risk for Alzheimer's. We're also going to study the retina, because the retina predicts the occurrence of how many years will it be before Alzheimer's, or for that matter, Parkinson's disease will show up. Now, I mentioned Alzheimer's, but this equally applies to the other 2 age-related diseases. What was interesting to see a cover in The Economist called "The Winning the War on Cancer." I think that was a little optimistic, but perhaps even the opposite direction is what's going on here in the United States with the radical cuts to the NCI and for cancer research. Not exactly canceled, but not getting the support that is vitally needed. The point being is, and most women in this country don't even know this, that they could get a normal mammogram and AI can accurately determine whether that normal mammogram actually shows a high risk for breast cancer in the next 5 years. There are 2 companies that have FDA approval for this, Clarity and Deep Health. No less AI reading of the mammogram to improve the accuracy as established through 100,000 plus people in Sweden who underwent studies to show a pickup rate of over 25% that would be missed by radiologists of important breast cancer. And this is just one of the papers that shows how a normal mammogram doesn't mean normal when you have an AI interpretation. And that's the point here. AI of our labs can pick up trends in normal labs that are actually very important, such as, for example, predicting pancreatic cancer, which is a hard diagnosis to make early. Here's another example. We don't do clonal hematopoiesis of indeterminate, it's not indeterminate, potential CHIP. We don't do this assay. We should be doing it. We argue whether people should take the risk of colon cancer, should take aspirin. But if you look at the people who have CHIP, they are the ones who derive remarkable benefit. Why don't we do that assay? Why don't we get the information for people so we can predict the diseases they're at risk for? And CHIP predicts both cancer and cardiovascular. So we can prevent many types of cancers by establishing who's at high risk, polygenic risk scores, genome sequencing, the immune system, and on, and getting ahead of this. Lastly, cardiovascular. This is a cover from a paper we had recently in Nature Medicine. We can predict who's going to get coronary artery disease now at a remarkably accurate rate. Not just who, but when. And this is a study we did from the UK Biobank and in the All of Us. And now it's even more powerful. There are 4 different companies that have an AI algorithm of CCTA, that is a coronary CAT scan, coronary CAT scan. And these companies have different methods for doing this. Medicare is now going to be paying. This is just for the AI, surprisingly. And so these 4 companies have the potential, particularly I think the one, Carista, which is the only one not yet fully FDA approved, but pending, picking up inflammation of the coronary artery when there's no obstruction, which is the whole goal of trying to prevent heart attacks in the future. Now, the retina I mentioned is rich. Why aren't we getting retina exams in everyone every year and having AI diagnostics? Because it's a window to every organ of the body, be it kidney, liver, gallbladder, the heart, of course, the neurologic conditions, subclinical coronary atherosclerosis. You can detect from the retina who is likely to have atheroma that's not of critical nature, but of its presence, of its importance, just by looking at the retina. Why aren't we doing this? Well, now there are 4 companies that are doing this. One of which, based in Hong Kong, is using this to predict the timing and yes, no of Alzheimer's risk, what magnitude of risk. Others are using it for cardiovascular risk. But that's just the beginning of use of the retina. Someday we will be doing selfies of our retina and having AI interpretation. I know that sounds funny, but it's not that far off. So the last thing I want to just run by you is what I consider a remarkably important study that appeared in Nature from Moritz Gerstung and colleagues from Germany. This was published in September in Nature. These are some of the headlines. The new AI model predicts susceptibility to over actually 1,200 diseases. This is yet another way we can find people who are at high risk and prevent them from having an age-related disease. This was the first large health model. So you are familiar with LLMs, language models. This is the token of health events rather than of words. So this is what an example is, predicting 20 years out based on the priors in a person accurately, not just if, but when, for basically all diseases. This was done with GPT-2 in 400,000 people in the UK Biobank, and then 1.9 million people in Denmark. And I spoke to Moritz about this finding. They were shocked how good it could predict the next 20 years at the individual level with a low parameter model. Of course, they're following up on this with much more refined models, but this is really exciting to see that we have other ways to predict with large health models. No less, we have sensors and the ability to integrate all our data through the emerging personal health agents. That was a preprint recently from the DeepMind, Google DeepMind group. And then another exciting new advance. This is from Shana Kelly from Northwestern. Many of you have tried a continuous glucose monitor to get every 5 minutes of glucose. But imagine if you could do that, the same type of patch on your arm or somewhere on your body to get continuous protein monitoring. And they've already shown, the group at Northwestern, that you can do this for inflammation proteins, not just one, but multiple. And this is something they're going to be going into clinical trials next year. And it looks very promising. So for people at high risk, yet another way to be on top of what's going on physiologically and biologically. So what I want to leave you with is the concept that what we call preventive care today is obsolete. It's totally inadequate. We're not preventing maybe some infections through vaccines. We get some chemistries, and maybe we'll jump on a high LDL. And then sometimes there's enough time to talk about healthy behavior. That doesn't even usually occur. The future, though, is to have a stack of data, the polygenic risk scores, ideally genomic sequence, at low cost. Both of those can be done along with CHIP for less than $200. We'd have the large health models. We'd have organ clocks. Tony and I were talking earlier this morning about cellular clocks. I mean, this is really such an exciting area. No less whole body clocks to tell if there's a gap from your chronologic real age to what is happening inside your body. We'll rely much more on these new biomarkers. p-tau217, I think, is one of the biggest breakthroughs to occur in neuroscience and probably in medicine for decades as far as having that biomarker. We'll be doing AI of the labs and the images and the retina, as I mentioned. We'll have these newer sensors that are even more beyond what we have today. We'll have personal health agents and even someday digital twins. So let me just leave you with that and just a few comments about aging. We've learned from the work, Tony, here about the 3 different peaks of aging through proteomics that's been reinforced by others, including another report from here at Stanford by Mike Snyder and his group. It's not linear. It's highly measurable. It's also modifiable with things that are pretty inexpensive, like lifestyle behaviors. Secondly, the pace of aging, as I've already tried to reinforce, is so heterogeneous between us and within us, and we now can measure that too. And that we shouldn't be using chronologic age anymore, only as an anchor, as a reference to the person's biologic age or organ age. And this is going to be the segue for us to be able to start getting ahead of the major 3 age-related diseases. That's how I think we can move to a new era of primary prevention. We've talked about this forever. We want to prevent these diseases, and we've never really done it. But now we have an opportunity, has to be tested and validated. We have an opportunity to actually follow through. So thanks very much for your attention.
Sure, we'll have a lot of questions. Start here.
Yeah.
Thank you so much for this really amazing talk. I'm wondering what your thoughts are. Who is going to do this preventive medicine? Is it going to be a physician? Is it going to be AI or a separate specialism? Or
I think the first wave is going to come from patients, because they're going to say, how come I'm not getting the data that is out there? And but I think eventually it will be, as you're positing, a combination of AI we need multimodal AI to do the integration of all the data. No physician, clinician could do that. So it has to be in concert. But yes, I mean, we have to figure out a way. First, we have to hopefully validate, starting with Alzheimer's, and I'm sure others will get into this, that you can prevent. And we talk about prevent, you can say, well, we changed the biomarkers and the brain clock, pace of aging, 10 years. That's pretty good. We'll take that. Now let's get it into clinical practice. And that's where you're at, which is we've got to get a whole movement. Once it's validated, that we have to implement it at scale.
Eric, fascinating talk as always, really brilliant. The science is fascinating, but I have to say, if someone asked me, would you recommend any of these amazing tests that you've shown? I would say I would recommend none of them. And the reason for that, and please show me that I'm dumb, is that the cost is exorbitant. I mean, you mentioned $200, which I would really question. That's not going to be just once. You know, if you do them like once a year for 10 years, that's going to be 2,000.
No, that's a genome sequence and
Well,
polygenic risk
genome
score. You do that
sequence-
once.
The genome sequence would be once, but you know, all the other, you know, p-tau and all the biomarkers and the brain scans and the,
There's
know,
no
the-
brain scans as
the
part of
clock,
it. So let me respond to you. It's very important.
Let me just
Okay.
run a calculation. Even with $200, you know, for the U.S. population, just now, be like 7 trillion. Okay. So you know, if you're 10 times off, which I think you're 10 times off in that price, this is 70 trillion. So we know that everyone wants and should have prevention with good diet, with not being overweight, with exercising. You know, all of that is wonderful for everyone. If you could convince me that I would just tell some people, oh, you know, go ahead and be obese because your clock looks fine.
No, I'm not suggesting that.
Okay,
So let me.
what are we doing?
Yeah,
What
I
is
get your
the-
point, John. And it's good to have a naysayer, and I'm sure there are others here. So first of all, there's many points here. How many people in the United States do the de minimis recommended exercise today? How many percent? Yeah, 20%, the minimal. So we have these criteria that people should, lifestyle is cheap, you know, improvements in lifestyle, but people don't do it. But if you have specificity in that this lifestyle is going to be important so you don't develop this really critical disease, that helps. Now, secondly, the cost of these things, you know how many people are going out and getting a total body MRI right now? Oh, okay. One total body MRI would pay for everything that I had on the list of prevention, all right? The other thing is these can be done at low cost, okay? So the genome work is done once. The p-tau you might do, you know, once every few years, okay? But that can be done inexpensively too. What we're going to try to do is get a package of these things, a package at a very low price, the whole thing for a few $100s. We're not talking about any scans here. There's not one thing on the list that's expensive that is using sophisticated equipment. We're talking about assays, right? So the thing that's the most important part of this is AI. That's software. That can be free, okay? So I want to also point out I want to say cockamamie calculation, but do you know how many trillions of dollars you save if you prevent just a little bit of Alzheimer's, a little bit of cancer? Do you know the treatments for cancer, how much they cost? Do you know what it costs to have one person in a home for Alzheimer's? You talk about the economic burden that is profound, profound. So what I want to just point out is this is a low cost investment for a high reward relief of our economic burden. Because if you look at the plot of our population structure, if it's demographics, and you look at these 3 age-related diseases and we don't do anything, talk about trillions of dollars. Yeah. Anyways, that's my comeback.
Okay, well, next question over here is Dr. Ash.
Hi, Steve Ash. I'm very proud to have Pascal Geltetzer in my division. But before I ask my question about that, you have convinced me that I'm going to skip dinner twice for the $200 for the p-tau and get it measured on myself to see if my wife's accusations of my developing Alzheimer's are correct or not. But could we really prevent Alzheimer's with shingles vaccines? It seems so. And it seems that even a randomized controlled trial, which would take hundreds of millions of dollars and 10 years to do, would not make me personally that much more certain that it would work. Is it time to just recommend shingles vaccinations for that purpose? Or do we need to wait for the RCT?
Yeah, I don't think we're going to see an RCT. And I think that the data we have in hand now with these 4 studies, one that was published yesterday in Cell and the other 3, we have enough now from the highest quality data, thanks to the work done here. 3 out of the 4 studies from here and the other one from Oxford that this is, the only question is, that's for age 50 plus. Should we actually lower the age that anyone who wants to get? We're not preventing Alzheimer's, we're chipping away at it. We also don't fully understand the mechanism, right? How much of it is potentially actually working against the virus versus how much is just the immune system and exactly what's going on with the immune system. But it sure looks impressive. And when you see concordance like that from one, across 4 different studies, I think it's undeniable. I also think that the public has missed out on this in the midst of this anti-vaccine landscape, that this is one of the most important things we've seen to prevent dementia. We're at the 20–25%. That's not 90%, but it adds to what we know with respect to lifestyle and other things that need to be explored. So I'm all in on this. I don't think there's even a need for a randomized trial of shingles vaccines at this point with the body of evidence we have together. Yeah, thanks for the work that's been done here. Wow. You know how many times I've quoted Stanford and I wasn't even trying. The work that's coming out here is just really, even though some people don't believe in the work, it's really impressive. Yeah.
Next question here.
You started to answer my question just now, but it was with regard to the natural experiment, the shingles vaccine. During your talk, it sounded like you said, you didn't think it was so much a direct impact on the virus versus immune modulation. And I was curious what makes you think that, especially given we know there's associations with other neurotropic herpes viruses and dementias as well.
The data are mixed so far. There's one recent paper in Nature Medicine suggested it actually is working on HSV. And then there's a couple others that suggest how could that be possible because there are all these other effects on the immune system. It's unsettled. So I take your point. We don't know. We just don't know. That's why in response to the earlier question, I said we really should zoom in on that. Yeah, important question.
Hi, my name is Yoni. I really appreciate a lot of what you're saying, and I don't mean to be a naysayer. I actually have a question about how you can help us understand. I take your point that a healthy lifestyle can be very preventative and in the long term save a lot of healthcare associated costs. But my experiences in the near term, a healthy lifestyle is often not cheap, and truly healthy food that doesn't have additives, is not processed, can be difficult to procure, and spending the time for healthy lifestyle habits and exercise for people with low income and responsibilities for different things in their life can be very difficult. And so how do you propose we kind of overcome that to eventually earn back the savings, but in the near term overcome that kind of hurdle and get that out to the people who might benefit most, who also have the most challenges to achieve it? Right.
I mean, that's important, and that is getting to the practical aspects. First you have to demonstrate, as we're going to do in the trial starting in January, that it works, that a very aggressive lifestyle coaching, virtually and human and, very continuous coaching, that it works. Then you have to say, okay, how can I do this in desert zones of food and people that are living on 80% ultra processed foods and, so yeah, there has to be a way to translate that. But as far as exercise, we've already seen many studies that show, and I reviewed them in the super agers, 4,000 steps is a big jump in improvement of outcomes across the board of age-related disease. So that doesn't cost anything to go for 4,000 steps for walk. Regarding sleep, most people don't know how important sleep health, not just for the brain, but also cardiovascular and cancer, right? So sleep health, people can be coached easily for that. We can use AI tools also to help with people's education about diet. We're supposed to have a movement of MAHA in this country, okay, which is a farce. It's anti-MAHA, whatever MAHA is, where we were going to get the bad ultra-processed foods out of the choices. What's going on there? Okay, so that sort of thing has to be coming from government policy. Other countries are getting all over the ultra-processed food. We're just lagging behind because of the Department of Agriculture, political issues, and whatnot. So I don't have a way to fix that one. Yeah, but we need to do it.
We'll probably end on Dr. Kim here.
Yes, hi. Thanks for such an exciting talk. I love all your terms like Wellderly. So here's my question for you is how do you make, I think you're touching on this, how do you make lifestyle sort of sexy for the patient level? I'm not sure. I have patients who'll do all this testing. They'll pay for it, but I'm not sure they'll walk 4,000 steps. And then I didn't hear you talk about,
I'm not sure they'll walk.
I'm not sure I can get them to walk
Oh.
4,000 steps. And then the second is you didn't mention any like social determinants of health,
Yeah.
which can also affect longevity. Thanks so much.
Yeah. Yeah, well, there's a lot of factors that it's not just the big three of, diet, sleep, exercise. I did mention about social isolation. There are the social determinants of health are critical. There's a lot of things on that list that we didn't get into, but I would just I call it lifestyle plus factors because it's extensive. So the question is, how do you get it to be alluring? Now, in Finland, they did a study where a large study where they gave people their polygenic risk score for heart disease. And they studied what happened and was remarkable. These people stopped smoking, they changed their diet, they started exercising when they had a high polygenic risk score. We have other examples that when people, instead of recommendations to all human beings, when it's particularized to a person because of their risk, there's a much better chance, not 100%, that you would get them to walk and you would get them to do things to prevent the disease. That not everybody is on a suicidal mission, So I do think that's some of the story here, that you say, Mrs. Jones, if we don't change things in 7.9 years, it's projected, we have that kind of specificity now. It's just going to keep getting better. And that, I think, is going to shake some people up. We're not there yet, but that's what basically extrapolating from the Finnish polygenic risk score study and others, that when you give a person their individual data, the chance of getting a better lifestyle as a start. Now, we cannot rely only on lifestyle. We need more than lifestyle because we have people that do everything right and they still get cancer and still get Alzheimer's. So it has to be more than just lifestyle. But the lifestyle is the cheapest of this to get. And if we had actually synchronized with the governmental objectives that we need healthcare policy, that would help expedite this. Yeah.
We always leave time for a little getting together at the end of this. You guys may have heard some beautiful piano music as you were waiting in that long line. Sorry about that, to get in here today. That's Dr. Chen, who will be raising his hand over there. He'll be our grand round speaker next week. Not only will he maybe teach us a little AI, but he'll also show us a little magic, taking us into the holidays. So please join us next week. I apologize. I know there's countless questions online. There's our satellite groups who've been reaching out, wanting to ask questions, and questions in here. So I'm so sorry we didn't get to all those questions, but perhaps Dr. Topol can spend a few minutes with us after. Dr. Topol, thank you so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.